Since the beginning of our history, mankind has searched for secrets of our natural universe, through exploration of space to the depths of the seven seas. But the true secrets of both are clouded by distance and our ability to see what hides above and below. Scientists and doctors have long searched to understand the processes taking place inside the human body. Through advances in technology, with inventions as varied as microscopes to the harnessing of X-rays and ultrasound, to get our first glimpse inside a living being. The search continues even today as we explore and understand the unseen secrets of our venous system. What causes changes in pressure, and how does a greater understanding of the 4 V's, veins, valves, velocity, volume, aid clinicians in better patient outcomes? Please welcome Dr. Moureau to learn about FlowRighteous, achieving 1 peripheral IV catheter per patient visit by exploring the 4 V's and hemodilution.
Our presentation today is titled, How to Be FlowRighteous, Understanding the Impact of Hemodilution. My name is Nancy Moureau, and you can see my information here. I've been a clinician for more than 35 years and am involved in a variety of activities from education to research to speaking and publication. Here are my financial disclosures. I am the owner of PIC Excellence, and not only do online education development for PIC Excellence, but also provide consulting for a number of companies, helping them with education and research. Let's talk about the most common scenario. A patient comes to the hospital with an infection. They come through the emergency department and have a peripheral IV placed in the antecubital fossa. By the time they reach the floor, that IV is hurting and uncomfortable for them. And so the IV is replaced and put into the right hand, which was the easiest location. Within 24 hours, that peripheral IV has fallen out while the patient was eating. This time, it takes multiple attempts in order to start another peripheral IV. And this time it's in the wrist. Well, you know how it goes. By the time the patient is discharged from the hospital, they may have 5 to 7 peripheral IVs because they weren't placed in a FlowRighteous manner. So what is FlowRighteous? And what are we trying to achieve here? The goal of FlowRighteous is to achieve greater than 90% success with peripheral IV insertion, with an overarching objective having 1 peripheral IV per patient hospital visit. The purpose of this presentation is to expand upon the understanding of blood flow within a vein and how factors such as vein diameter, valve location, velocity of blood flow, and volume of blood flow, coupled with a patient's prescribed infusion flow rate, all affect the optimal delivery of medications so that you can be FlowRighteous in your understanding of the need for adequate hemodilution. Whether you're a chief nursing officer, a vascular access specialist, or bedside nurse, or other clinician, here are some important statistics for you to consider. You may know that there are over 350 million peripheral catheters sold per year. According to the American Hospital Association, in 2018, they indicate that there were only 36 million total acute care admissions in the United States. That equates to about 10 peripheral catheters per patient. Something's wrong there. That's a big wow for anyone paying attention to the data on quantity of peripheral catheters attempted or used. Becoming FlowRighteous can help everyone. Doesn't every patient deserve a higher quality of care with 1 stick success? Make the choice and move to becoming more FlowRighteous. Select the vein in the right location and give the patient the best chance for a catheter to last through completion of therapy. So what is FlowRighteous? FlowRighteous is the ability of a vascular access specialist to select an optimal peripheral catheter site based on specific parameters of the 4 V's and the patient's medication with corresponding infusion rate. The concept of FlowRighteousness is a new level of vascular access expertise that supports vein evaluation to deliver reproducible, optimal result of one peripheral catheter per patient visit, with resultant longer dwell times and few, if any, complications. Many current measurements fall short of achieving the end result of better outcomes because they fail to account for aspects of flow and focus more on quantifying vein diameter, radius, and area. According to recent research, better outcomes may be more about flow than diameter. Gaining an understanding of how to successfully choose a catheter and vein, one designed to be the best for treatment, is done by embracing the detailed concepts of anatomy and the science of hemodilution. Flow righteousness can only be achieved through a better understanding of vein physiology with application of the assessment parameters. Our objectives for this presentation are to identify the goals of flow righteousness and how these goals and objectives can help to reduce IV complication rates such as occlusion, infiltration, and phlebitis. In this presentation, I'll talk about the 4 V's: vein selection, valve location, velocity as the speed of blood flow, and how the volume of blood flow applies to the hemodilution ratio. We will compare how evidence of the 4 V's coupled with the prescribed infusion flow rate can provide valuable insights into the wonderful improvement in your patient's peripheral IV catheter dwell time. To meet the flow righteous goals with vein selection of optimal flow and hemodilution, we also need to select the best vein in the forearm with an adequate vein diameter, good blood flow, a catheter of adequate length inserted with a low angle of insertion, and designed to float the catheter in the center of the vein while avoiding valve. We need a vein with a diameter large enough to accommodate a catheter to vein ratio of greater than 50%. A vein which has blood flow velocity and volume of blood flow, which together can achieve a hemodilution ratio of 3:1 in comparison to the prescribed infusion flow rate. All of this working together can allow for the best catheter performance. By avoiding valves and having adequate hemodilution ratio, the vein wall is protected and the catheter and vein continue to function well. This flow righteous selection process is designed to reduce or eliminate IV complications such as chemical or mechanical thrombophlebitis, which causes premature catheter failure. The flow righteousness 4 V's of vein, valve, blood velocity, and blood volume all add up to optimal characteristics that must all be in alignment to be considered flow righteous. Think 4 V's. The choice of a specific zone is one of the basic factors that adds up to be the best location and vein within that area. Why you choose a certain area and vein should be based on a systematic selection process. Much of the clinical practice today leads us to choose veins based on first to locate, easiest to stick, and most convenient for the inserter. A component of the systematic approach of the 4 V's is the application of the zone insertion method, as described by Dr. Dawson in 2011 for peripherally inserted central catheters. This zone insertion method can also be applied to peripheral catheters to achieve the optimal vein selection within the red, yellow, or preferably green zones, demonstrating optimal location to find flow righteous veins. Know the factors affecting veins and catheter longevity to gain a better site selection. The 4 V's of flow righteousness are vein, valve, velocity, and volume. The vein component establishes the best location while confirming the proper diameter. Valves are a necessary consideration for the positioning of the catheter with an optimal distance and avoidance of contact. Velocity is a newer component that works with volume of blood flow to ensure proper mixing and movement of the infusate to protect the vein wall. So let's consider the more detailed aspects of each of these flow righteous components. This animation reinforces the anatomic life flow within our body. When we think of systemic circulation, we must consider the high-pressure arterial blood flow and the low-pressure venous flow. This system of circulation is central to the basic body homeostasis and foundational to the concepts of vascular access function. Through valve function and velocity of flow, blood moves through the body to bring oxygen and nutrients to all corners of the organs and extremities. Consider the details of systemic circulation as it relates to infusion therapy, starting with arterial flow. We know that arteries are highly pressurized, with an ideal systolic pressure of 100 millimeters of hemoglobin generated by the left ventricular pump. As the arterial blood courses through the body, there's a transition to a lower pressure as it approaches the arterioles and capillary beds. The pressure drops to 35 millimeters of hemoglobin. Then, as it enters the venous system, pressure levels out between 8 and 12 millimeters of hemoglobin on its journey back to the heart. Reaching the right side of the heart, it circulates and the pressure drops to 4 millimeters of hemoglobin, reinforcing the low pressure flow reality of the venous system. We know circulation manifests at a volume of 5 to 6 liters per minute of blood flow in an average adult. With infusion of a solution through a catheter in the venous system, pressure is affected, resulting in both increases and decreases. These changes in pressure in the venous low-pressure system can cause retrograde blood flow into and around a catheter, depositing blood cells and platelets that attach to the walls and inner lumen of the catheter. Maintaining functionality of an intravenous catheter within the venous system requires us to consider multiple factors. The first component of the 4 V's is vein, and the factors that add up to choosing a FlowRighteous vein. This selection is established through identification of specific vein location, size, and advantages or disadvantages of each. Some basics about veins and vein types. The purpose of veins is to return deoxygenated blood to the heart from all the organs in the body, as we've talked about. The large veins parallel the large arteries and often share the same name, but the pathway of the venous system are more difficult to trace than those of arteries due to the many variations, especially within the extremities. Superficial veins are in the hypodermal adipose layer under the dermis. These veins have the same type of valve as the deep veins, but are not surrounded by muscle, and thus the blood in the superficial veins typically moves much slower than blood in deeper veins because the pressure is less. Deep veins are located within the muscles and parallel to the bones. Veins that connect the deep with the superficial veins are called connecting veins or branching veins. These larger, deeper veins can be seen within the veins such as the brachial veins that run parallel to the brachial artery. Much of the blood that flows through the superficial veins is diverted into the deep veins through the many connecting small branching veins that run between the deep and superficial veins. During times of stress, blood is diverted into the deeper veins, with the connecting veins constricting, resulting in limited flow to and within those superficial veins. Factors that affect quality and suitability of veins for infusion therapy, as we mentioned, include the diameter, the valves, the velocity of flow, and the volume of blood, and then the location. Diameter of a vein can vary based upon the patient's physiology and size. The largest vein diameter for the forearm is usually found in the upper forearm closest to the antecubital fossa. Valves divide vessels into segments, and the distance between those segments increases as you move up the arm, away from the hand and wrist. In our recent, yet-to-be-published study, the vein characteristics that we collected included diameter, location of veins, bifurcations, valves, and identification of areas straight enough to accommodate a catheter. The vein diameter was not directly correlated with higher or lower velocity. However, volumetric flow rates tended to be lower with vein diameters that were below 2.9 millimeters. The hemodilution calculations confirm natural turbulence within blood and retrograde blood reflux with valve opening, closing, and flushing that occurs, as shown in the video documentation soon to come. Areas of turbulence with flushing create a backflow of blood around the catheter and can affect functionality. As established by William Harvey in 1628, the purpose of valves is to keep blood moving back towards the heart. What is specific and amazing about the venous system is the unidirectional blood flow and homeostasis within the body. With the contraction of each muscle during movement, Pressure is applied to the vein, causing opening and closing of valves in association with those pressure changes. The muscle pumping action in deep veins causes opening of proximal valves and closes the distal valves, preventing backflow. Very little muscle is around superficial veins, causing flow to be contingent upon pressure with the veins, body movement, and deeper vessel function. The basic function of a valve is to open and close, often during diastole when the pressure is low. As you can see in the image, valves in the venous system consist of two flaps, also known as cusps or leaflets. Incompetent venous valves that stay open can lead to significant venous stasis, insufficiency, edema, skin hemosiderin changes, and venous ulcers in the lower extremities. Valves are located approximately every 5 to 7 centimeters in the extremity, with fewer valves in the antecubital fossa and up the arm. The larger the diameter of the vein over the area of the valve aids in visual identification of that valve location, making it easier to avoid the valve or avoid inserting near a valve. When branching or vein bifurcation points can be identified, valves most commonly precede that branch. Valves impede retrograde blood flow at these branch points and may contribute to vessel collapse if the vein is deprived of retrograde filling. The impact of a catheter in the vein is that closure of the valves and collapse may in some cases promote blood coagulation that covers and occludes the end of the catheter. When a tourniquet is applied, causing vein distension, venous blood flow is stopped and may result in pooling of blood, causing slower closure and inactivity of the valve that may also contribute to coagulation. The body's circulating enzymes of urokinase help to break down small clots that form throughout the body's venous system, but sometimes even this isn't enough. Let's be righteous about valves to understand their impact on flow. The valve function is based on hydrostatic pressure, causing opening and closing of the flaps. In terms of hydrodynamic function, William Harvey's experimental work resulted in the development of the theory of circulation, which led to a better understanding of blood flow and identification of the presence and importance of valves. Blood, as it moves toward the heart, pushes the valves open like a pair of one-way swinging doors. If gravity or muscle contraction try to pull the blood backward, or if blood begins to back up in a vein, the flaps are pushed closed, preventing backflow. As you can see in this diagram, the valve cycle phases moves from closed to opening to equilibrium to open to closing. Note the branch connectors, the image that dilates or contracts based on the needs of the body. Thus, valves help the return of blood to the heart by opening when the blood flows toward the heart and closing when the pressure drops. The first venous valves, cranial from the heart, are found in the subclavian and internal jugular veins, not far from their confluence, which forms the innominate vein. These valves have a certain importance in connection with infusion therapy. If the tip of an intravenous catheter is located on the cardiac side of these valves, pressure increases with the infusion cause the valves to close during the infusion. The infused volume will reach the heart faster than if the infusion was instilled in a more cranial vessel. Changes in pressure in the venous low-pressure system causing valve closure may result in retrograde blood flow or reflux into and around the catheter, depositing those red blood cells and platelets into the catheter and attaching to the walls. Flow of solution through the catheter helps to maintain patency. However, we've all observed occluded catheters and often blamed it on lack of flushing, when in fact it may actually be normal functioning of valves and blood flow resulting in occlusion due to retrograde or reflux of blood. Valves are an important factor affecting flow. When valves are open and closed, they create natural turbulence, causing changes in blood flow, both in direction and pressure, as you can see in these images. It's generally accepted For veins to maintain adequate blood flow around a catheter, the vein should be at least twice as large as the diameter of the catheter, as noted in the research by Dr. Nifong and Associates in 2011. Without adequately maintained blood flow around the catheter, the vein lumen may experience slower flow and increased coagulation. Within the veins, the number of valves increases distally so that retrograde reflux of blood may be stopped and flow maintained toward the heart. The hydrostatic pressure fully affects the superficial and deep veins. Muscular contraction occurs with systole. The blood is pressed in a proximal direction. As the competent valves of the peripheral venous system will promptly close, only one direction of blood flow is possible. Muscular relaxation occurs with diastole. The pressure in the deep veins of the legs drop rapidly, causing the valves of the popliteal veins to close. Simultaneously, blood is drawn from the superficial venous system and the muscle veins, resulting in an increase in pressure. This forces the valves of the popliteal veins to reopen and the cycle to recompense. A major exception is seen in the valves communicating with the veins in the foot. Many of these veins have no valves, in which case a bidirectional blood flow is possible. If valves are present, they control the blood from the deep to the superficial veins, such as in the opposite manner as found in other regions of the arms and legs. This is due to the fact that with every individual step, blood is pressed from the plantar plexus. The French use the term semaine veinule, or venous insole, moving the blood into both the deep veins and also in the superficial veins with every step. Veins and valves that drain the blood from the lower extremities are without a doubt the highest clinical importance for the return of blood to the heart, and should be avoided for infusion therapy. For upper extremities, vein injury and closure of valves may occur when intravenous catheter insertion penetrates at or near a valve. Even close proximity to a valve can cause changes in blood flow that affect hemodilution. In simple terms, valves open and close in response to increasing blood volume and pressure behind the valve. In contrast to the clinical significance of leg and pelvic veins, the valves in the branches of the superior vena cava are rather modest, with no valves in the superior vena cava or the inferior vena cava main trunks. Valves are distributed throughout the venous system in various patterns, often adjacent, inferior, or superior to bifurcations or branching veins. In 1927, Franklin noted that valves do not occur in veins with a diameter of less than 1 millimeter. His findings are confirmed by Spateholz and Rolfs in 1958, as well as by other authors. According to Keith in 1907, the superior vena cava, the inferior vena cava, along with the innominate vein, the hepatic and renal veins, and the iliac veins, all serve as reservoirs with a capacity of some 430 milliliters of blood, which is of great importance for regulation of circulatory homeostasis. Considering published literature on blood flow, we can identify evidence for vein diameter, valve location, and branching veins superficial to deep connectors. Peripheral, antegrade, or forward blood flow around a catheter is limited by initial vein lumen diameter. In addition, retrograde blood flow back to the central circulation may fail due to the presence of venous valves or the absence of branches existing in the upper extremity superficial venous system. Given the anatomy of veins, including venous valves and branches, there are noted changes from the peripheral hand veins to the antecubital fossa, indicating that catheter placement location also affects overall function. Spivak and his team mapped superficial veins in a large sample size of 14,000 measurements in upper extremities. They showed the mean cephalic vein size in the upper arm was 2.4 millimeters, antecubital 2.7 millimeters, and forearm 2.1 millimeters plus or minus 1.2 millimeters. They showed the decrease and increase in diameters over time. Research in 2017 by Gagné and Sharma investigated location of valves and how diameter and position and branches affect catheter failure rates. In this research on the relationship of common vascular anatomy to catheters, they studied superficial veins used for intravenous cannulation and the branching segments between those superficial and deep veins. Their work confirmed valve distribution, blood flow, and the occurrence of vein collapse due to blood closures and changes in the pressure caused by infusions. Lurie and Associates, earlier in 2003, also described the phases of valve activity and hemodynamic events that play a part in blood movement, retrograde blood flow, and turbulence that acts to prevent stasis around the valve flaps. Based on their findings, a venous branch could be found every 5 to 7 centimeters, as we've talked about. Predominant configuration was a valve immediately before a branch, whereas 19% of the observed adult veins had branching veins in larger diameters, with the suggestion that a branching vein was the dominant source of peripheral to central blood flow in the superficial venous system rather than the observed vein. In 26% of all image segments, they had no valves, and veins of the antecubital fossa were much less likely to have valves. Veins of the hand and forearm were nearly equal in their frequency of valves distribution. In those vein segments of the hand with valves, there were often multiple valves identified within a 10-centimeter segment. These researchers suggest in order to optimize peripheral catheter success, veins are cannulated so that the tip of the catheter is placed close to a branch while avoiding valves. Select an optimal peripheral gauge for each vein, balancing the vein diameter and the catheter lumen diameter. And finally, their results indicate ultrasound visualization of vein diameter and local anatomy during insertion may increase the likelihood of optimal peripheral catheter placement and the ability of placed catheters to maintain full function for the duration of treatment. Ultrasound guidance during placement can offer more information on valve location and optimal position of the catheter before, during, and after catheter placement. Research and publication on circulation and blood flow goes back as far as the early discoveries of the 17th century. Some of the more recent investigations of blood flow and the impact on patient outcomes is represented by some of these authors. In the vein diameter measurement study by Plankin and Associates in 2006, they found diameter ranges of 0.7 to 3.3 millimeters in the superficial veins of the forearm, with variation of vein diameters based on pressure applied from tourniquet or blood pressure cuff. And clinicians performing the measurements also had variations. In 2018, the published work of the European Federation of Clinical Chemistry and Laboratory Medicine, they validated the most common configurations and variations of veins in the forearm in their recommendations for venipuncture. In the work of Nifon and McDermott on catheter-to-vein ratio laboratory models, they showed that blood velocity decreased in proportion to increasing catheter size or vein obstruction. As part of the 4 V's, velocity is the third V and represents the speed at which blood flows. Velocity of blood flow correlates with the rate of medicine infusions. We know intravenous medication administration has an immediate 100% absorption at the time of infusion. Intravenous administration enters the systemic circulation directly and is taken into the cells upon contact. The primary purpose of giving medications intravenously is to initiate a rapid systemic response and to maintain drug levels in the blood to achieve an adequate therapeutic response. Velocity and volume of blood allow for dilution, and move the medications into the main circulation while potentially avoiding vein wall irritation or injury. Dehydration, hypothermia, and peripheral neuropathy will all impact blood flow velocity. Much more difficult to measure with some ultrasound devices, velocity plays an important role in determining if a vein is suitable to manage an infusion through a catheter. Difficulties with velocity of blood become more apparent when the infusion rates increase above 80 milliliters per hour. The factors affecting optimal vein selection also involve volumetric blood flow. The fourth V is represented by volume. The volume of blood flowing in a vein through a section is dependent upon the physiological hydration status of the patient, the diameter of the targeted vein, the speed or velocity at which the blood is moving, which was found during the ultrasound Doppler assessment, converting the linear blood flow of blood velocity in centimeters per second into a volumetric flow rate in centimeters per second or milliliters per second or per minute or hour, allow for the calculation of volumetric flow where linear blood flow and diameter factor into the equation. As pressure increases or decreases within the venous system based on the opening or closing action of the valve and the pressure within the vein, the blood moves back towards the heart as a result of this valve action, and the blood flow velocity increases. As velocity increases, the volume of blood in the vessel may diminish in the smaller vessels as related to this and other physical factors of anxiety, organ requirements, sepsis, and other stressors. The greater the distance from the hand or wrist and the larger the vein, the greater the velocity, with pressure causing the blood to move faster towards the heart. The blood flow volume increases as the vein diameter enlarges. More space, more blood. The upper forearm is a common location for intravenous catheter cannulation, as it's straight enough to accommodate a catheter without kinking. This area has a greater distance between valves and better vein diameter than veins in the lower forearm, and increasing volume and velocity. Mixing of medications and infusion solutions in blood can be compared to adding color to paint. The slower the mixing process, or blood velocity, the slower the dilution of the substance. Small volume, slow velocity, and the action of valves all affect the ability of the infused solution to mix adequately into the blood and protect the vein from irritation. The better the hemodilution and mixing, the faster the action of the medication and more biocompatible. Some significant literature has been published on hemodilution and ratios necessary for optimal infusions. In 2017, Roethlisberger established a parametric approach, comparing it with conventional and experimental approaches to determine maximum volume of infusion. Dilution ratio at the point of infusion can be determined according to infusion time. Intravenous parenteral solutions and medication should aim towards being isotonic and anhydric. In other words, establishing a physiological pH when infused into blood. Yet, due to other considerations, this goal is not often reasonable or doable. There are no clear allowable ranges related to pH and osmolarity. However, because many factors play a role in terms of level of irritation and local tolerance of the vein, such as administration site and route of administration, vein selected, related venous blood flow, injection volume, infusion time, infusion, no well-defined and generally recognized pH, buffer strength, all of these factors play a part. By identifying blood velocity in centimeters per minute, an average of 7 to 15 centimeters per second can be established for veins measuring 0.15 to 0.035 centimeters, revealing blood flow in milliliters per minute. The ratio of blood flow is divided by the infusion rate, where the flow of blood, or FBL, is a quarter of the blood flow in milliliters per minute. Velocity of blood, or VBL, is a quarter in centimeters per minute. Diameter is 1/4 of the vein diameter in centimeter, and the R is represented as a quarter of the radius in the vein diameter in centimeters. Some of the work by Spencer and Mahoney with their catheter-related thrombosis risk reduction tool in 2017 built on the components of the same approach. In his research, Dr. Roethlisberger stated, the better tolerability of an IV administration in comparison to peripheral or central injection is explained by the dilution effect of blood directly after injection. He determined to minimize local irritation of the vein, the infusion rate should not be higher than 1 ml in 10 to 20 seconds, or 6 milliliters per minute. This works out to a hemodilution ratio of blood volume of 3 to infused volume and velocity of 1. As a result, optimal administration of any intravenous medication or solution through a FlowRighteous vein is with this 3-to-1 ratio of hemodilution. Establishing a systematic process for evaluating peripheral veins is necessary to find those most suitable for cannulation and administration of certain therapies. Incorporation of the 4 V's into the process allows a quantitative measure of expected performance of the vein. First, perform the zone and diameter assessment of the available veins in the forearm using ultrasound. Next, choose the location with diameter, zone, and vein that best fits the criteria for the straight path and the valve separation. And third, verify the 4 V's through the valve identification, velocity, and determination of volume for each vein evaluated. Verify the rate of infusion needed for the prescribed therapy. With these characteristics of the vein, valve, velocity, blood volume, and rate of infusion, the hemodilution ratio can be effectively calculated. A 3-to-1 ratio of blood flow to infusate, or better, is necessary to be considered FlowRighteous. While we recognize that careful vein selection is important, gaining an understanding of how to successfully choose a catheter and vein designed to be best for treatment is done by embracing the detailed concepts of anatomy and the science of hemodilution. Many current measurements fall short of achieving the end result of better outcomes because they fail to account for the aspects of flow and hemodilution and focus more on quantifying vein diameter, radius, and area. We now know that better outcomes may be more about flow than just vein diameter or size based on the research that's been done. Part of systematic vein selection with the 4 V's is based on the zone insertion method, as we've talked about by Dr. Dawson in 2011. The red zone represents the area of flexion and small vessels of the hand and wrist to be avoided unless no other options exist. The yellow zone consists of the lower forearm, where small veins predominate, requiring careful selection. And the green zone, which we would consider the optimal zone, includes the upper forearm, where larger diameter veins are common, leading to the selection of a FlowRighteous vein. While selection within the green zone provides the greatest options for finding a FlowRighteous vein, representing the opportunities for greater success or failure, but zone selection alone does not equate to optimal success. When we look at the individual areas or zones, within the red zone, there are many small veins having low volume of blood flow and low velocity. Areas of flexion and small vessels of the hand and wrist should be avoided unless no other options exist. These veins are tempting due to their superficial appearance. The more valves, the fewer the number of usable sites for catheter insertion in this area. Despite surprisingly higher velocity of blood moving through the veins, The active valve opening and closing helps to facilitate the forward movement of blood. Infusion of medications is likely to have minimal hemodilution due to the lower blood volumes and cause greater vein irritation. In this area, it is about size, but also about volume. The yellow zone is present in the lower forearm, where small veins predominate, requiring careful selection, especially on the dorsal side of the wrist where there are veins that, if accessed for infusion, may cause serious complications due to the carpal tunnel region. In addition, this dorsal area can be very sensitive, causing greater pain with insertion. This area is also in close proximity to arteries and nerves. Within the wrist area, veins, nerves, and arteries travel through the carpal tunnel with a very tight fit. Any infiltration, swelling, or irritation associated with this area can be severe and cause permanent injury. By avoiding the area of flexion, approximately 4 centimeters at the wrist, and focusing on the smaller region up to the midpoint of the forearm, vein selection in the yellow zone is based on assessment of vein diameter, depth, and location of valves with branch points, which are common for these more superficial veins. The green zone is represented as the mid to upper forearm. This region has some larger veins that can meet the FlowRighteous test of the 4 V's. As vessels from the lower forearm join, vein size and blood volume increases. The upper forearm has a stable, secure location without a point of flexion, if positioned well below the antecubital fossa. Longer peripheral catheters may be needed in this area, since many larger veins may be deeper, requiring ultrasound guidance and the extended length of the catheter. Care should be taken to avoid advancement of peripheral catheters into and beyond the antecubital fossa whenever possible. Putting all this together with the 4 V's and the zone selection requires understanding and training for best application. So, who is the most qualified to take ownership of a FlowRighteous approach and selection? Time has come for all vascular access specialists and teams to insert all IVs. Evidence is growing and it all points to certain truths. Maximum safety and satisfaction cannot be achieved with the current situation of convenient sticking wherever the easiest vein is found. Specialists for efficient insertions are vital, especially in the crisis such as we've experienced with the pandemic. Patient-focused care requires us to rethink how to do things better. As a specialist, you are important. You are vital to patient-focused care. You save money. You are a superhero with superpowers to find that perfect FlowRighteous vein, to place a catheter with one attempt, and to guide the maintenance practices in the best way for the patient. So how can those superpowers be best used? Research on the first V in the systematic process for vein size, mapping, velocity, valves, and flow has been limited. As a result, a recent research study was conducted looking to better understand the elements necessary for vein selection. The data in this chart represents a study performed on 10 volunteers to determine the parameters of the 4 V's. Vein diameter measurements without a tourniquet had an average of 2.1 millimeters and 2.5 millimeters with a tourniquet in the basilic vein of the lower forearm. The cephalic vein of the lower forearm averaged 2.7 millimeters without a tourniquet and 2.9 millimeters with. The upper forearm basilic showed an average of 2.25 millimeters without a tourniquet and 2.8 with. The cephalic, 2.5 millimeters without and 2.95 with. In the antecubital fossa, the diameters were larger and averaged 4.1 millimeters without a tourniquet, and surprisingly not much more with a tourniquet at 4.15. You can see the ranges of diameters from low to high started at 0.5 to 7.2 millimeters. The variation in vein diameter sizes in the 10 subjects for lower and upper forearms and antecubital areas demonstrated suitable and unsuitable veins. The upper forearm for basilic and cephalic veins identified the largest number of suitable veins in comparison to smaller veins in the lower forearm. Next, the research focused on velocity, measured in milliliters per minute within the vein. Velocities were low at 0.2 milliliters per minute up to 183.2 as the range for all areas of the arm with and without a catheter in place. Velocity measurements diminished significantly with catheter placement in many cases. However, velocity measurements with flushing of the catheter topped at 3817 milliliters per minute. Let's apply this information while looking at the specific subjects and practical applications. When we consider subject number 4, vein presentation, we see a young female of average size with no visible superficial veins in the green zone. Without a good pre-assessment, what would a generalist nurse do? Probably insert in the hand, wrist, or dorsal aspect of the wrist. Following an ultrasound assessment on the right cephalic, it was identified with a diameter of 1.2 millimeters without a tourniquet and 2.0 with. In this case, the starting velocity of 4.3 centimeters per second was measured before a 22-gauge catheter was placed. The velocity increased after placement to 6.1 centimeters per second. The catheter filled approximately 75% of the vessel and represented a high risk for failure due to the poor catheter-to-vein ratio. The volume of blood moving through this vein was calculated at 4.14 milliliters per minute. A valve is distal to the tip of the catheter without catheter contact. During the flushing process, retrograde blood reflux, turbulence, and vein collapse was noted due to pressure changes. It was determined that this vessel size and velocity was adequate to achieve greater than 3 milliliters per minute of flow. Taking into account a rate of infusion at 80 milliliters per hour, the hemodilution ratio is optimal at 3:1. But when infusions increased above 80 milliliters per hour, up to 125 or 250, the ratio of blood flow falls below the optimal 3:1 and down below 2:1. As you can imagine, with larger infusions such as vancomycin requiring 250 milliliters per hour, this can create a problem for the vein in order to accommodate and reduce irritation to the vein. Pre-assessment of this particular patient could identify this vein as suboptimal and recognize another option of a larger or upper arm vein that would be a better selection, allowing the patient to avoid multiple attempts by the bedside nurse or emergency department clinician. In this next case, a healthy volunteer, the application of the 4 V's is demonstrated in a 54-year-old, 290-pound male. The veins in this subject are good, representing the upper range of the input data in our study. Observationally, superficial veins are visible in the forearm region. Without ultrasound assessment, a vein would likely be selected in the yellow zone, even though larger veins are present in the green zone. Upon ultrasound assessment, the vein diameter was found to be excellent at 4.1 millimeters without a tourniquet, even in the lower forearm, and a 5.1 millimeter with a tourniquet. Following placement of a 22-gauge catheter with a 1.75-inch length, the catheter-to-vein ratio was identified as taking up 25% and well within the good range for catheter-to-vein ratio. A valve was noted distal to the catheter tip, and the velocity measurements came in at 8.6 centimeters per second. The volume measurement was 68.13 milliliters per minute. When applied to the formula for the hemodilution ratio, we find that for an 80 milliliter per hour infusion, The ratio is quite high at 51 to 1. As the infusion rate increases to 250 milliliters per hour, a 16 to 1 ratio applies. All of these were within the optimal range for hemodilution and best outcomes. In this video, you can see a demonstration of the flushing catheter. The catheter is suboptimally positioned flat on the bottom of the vein. You can also see retrograde blood reflux, turbulence, and vein collapse that occurred during flushing. In contrast to the previous cases, this 56-year-old female had vein selection challenges and represented the mid-range of our subjects. In this case, no superficial veins were visible, and likely without an ultrasound would be inserted in the red zone of the hand or the antecubital fossa. Using the zone insertion method for selection is a bit more difficult in this case. In the upper forearm, we do identify veins with ultrasound for the basilic and cephalic, having diameters of 3 to 4 millimeters. The left upper forearm cephalic was selected with a diameter of 3.5 millimeters without a tourniquet and 3.7 width. The 22-gauge 1.75-inch catheter was inserted. The catheter-to-vein ratio was less than 25%. A valve was present distal to the tip of the catheter, and the catheter avoided the valve. Flushing revealed retrograde flow and turbulence. The vein blood velocity was 3.6 centimeters per second following catheter placement. The volumetric flow was calculated at 20.78 milliliters per minute, and the hemodilution ratio of greater than 3 mils per minute. This case had a lower hemodilution ratio, but it was still well within the 3 to 1 parameters, even at an infusion rate of 250 milliliters per hour. So what is the value to the patient? Gaining an understanding of how to successfully choose a catheter and vein designed to be the best for the treatment is done by embracing the detailed concepts of anatomy and the science of hemodilution. Many current measurements fall short of achieving our end result of better outcomes. According to the recent research, better outcomes are more about flow than diameter. Using the 4 V's to apply the systematic process, we can do our best for the patient. You're already aware that careful selection of intravenous devices provides huge value to the patient, with longer dwell time and fewer complications. We see these results in publications where specialists perform insertions and maintain intravenous devices. Greater success, less phlebitis, and longer dwell are present in these types of catheters. In one study by Clyden and Associates, pediatric patient insertions of peripheral catheters by specialists demonstrated 40% better outcomes and longer dwell times. In another study by Steer and Associates, the specialist group reached end of therapy with one device in 89% of cases. Patient satisfaction definitely increases with the knowledge that an inserter is well trained and efficient with the procedure. What's the value to the clinician and the facility? What does FlowRighteous do for you and your facility? Well, think in terms of flow process control, patient satisfaction, efficiency of time, and reduced waste that translates into cost savings. These are all valuable factors. In the Steer PIV 5-Right study at Hartford Hospital in Connecticut, they realized more than $1 million in annual savings by applying the model and higher level of assessment. Reducing peripheral catheter usage by using specialists for all insertions translated into tremendous savings. Not only savings, but happy nursing staff and happy patients. The bedside nursing staff satisfaction increased, as did the patient satisfaction, with one device for the whole length of therapy. Why FlowRighteous? And why going to the trouble of applying a systematic approach to the 4 V's to determine hemodilution for a patient vein? To improve outcomes for our patients and to become fiscally responsible with healthcare, we must move to the next level and begin to train and apply these principles. We now know how to become FlowRighteous to reduce catheter failure rates and to decrease variability in skills with vein selection and insertion. Yes, it may require improved ultrasound and calculations. Currently, there is work being done with an app that will allow for easy access to the formula for hemodilution calculations and validation of suitable veins. We're all in a learning process. Within this systematic and reproducible method, it is possible to achieve one catheter per patient, which benefits the patient and the healthcare institution by allowing you to achieve significant savings and safety through more efficient insertions. Over time, this process of applying this systematic method of selection and insertion to become FlowRighteous will become faster, improved to the point that may allow us to achieve our main goal, which is to make vascular access device complications history. In conclusion, FlowRighteousness is reflected in the selection process, evaluating the 4 V's. This level of evaluation requires a specialist, someone trained in ultrasound assessment techniques, such as one within a vascular access team, to select an optimal vein based on these parameters. The 4 V's of veins, valve, velocity, and volume go beyond diameter and catheter-to-vein ratio, applying characteristics of flow and hemodilution ratios. FlowRighteousness can only be achieved through evaluation and application of vein physiology for optimal hemodilution. How can you achieve the greatest success for your patients and become FlowRighteous? Begin to practice higher level evaluation of patient veins with application of the 4 V's. Train yourself to consistently assess veins, valve location, velocity, and volume of blood flow up to a level that you're able with the equipment that you have prior to the insertion of any intravenous device. The very best institutions will study the results and collect data on the outcomes. The scientist Schopenhauer once said, "Research is to see what everybody else has seen and think what nobody has thought." What we are proposing is a new level of vascular access expertise with highly trained specialists to deliver reproducible, optimal results of 1 peripheral catheter per patient visit. That's superhuman powers. Take your evidence and present the outcomes with financial impact of reduced attempts and longer dwell to your administration staff so they can realize the full financial impact and value of specialists. Examine the 4 V's through education and training of all insertion staff. Incorporate bundled practices like the PIV 5 rights and research to support the use of trained specialists with superior ultrasound skills for all difficult access patients. Ideally, use specialists for all intravenous access and management to fully gain the patient satisfaction and benefits with financial savings and supply reduction. Apply the 4 V's to your patients every day and realize the positive results of FlowRighteousness with hemodilution and the 4 V's.
Like exploration of space and the ocean, we are continuing to learn new things about the body, but the true secrets of both are clouded by distance and our ability to see what hides above and below. We have seen how the flow of blood with pressure variations can create retrograde flow. We are still learning new things about the 4 V's, veins, valves, velocity, volume, and the importance of hemodilution. Now, with a better understanding of vein valve characteristics and advancements in reflux prevention, we can continue to institute new practices for extending catheter life, as well as rethinking current practices for the delivery of intravenous infusions, such as implementing target zones for optimal catheter insertion. As medicine progresses forward, each and every one of us plays a role in discovering and further understanding the venous system, the 4 V's, and hemodilution. Thank you for taking this journey with us today. Our hope is that each of you will apply this knowledge to promote the goal of 1 peripheral catheter per patient visit so that we can all be flow righteous.